Hello, my name is Dickon Hayne, and I'm going to be presenting adding mitomycin to BCG as adjuvant intravesical therapy for high-risk non-muscle invasive bladder cancer, a randomized phase 3 trial, or the BCG+MM trial. Those are my conflicts of interests and disclosures. So adjuvant intravesical BCG with maintenance does reduce recurrence and probably progression in high-risk non-muscle invasive bladder cancer, but there is still, despite optimal therapy, a high rate of recurrence and progression. Meta-analysis seems to suggest that sequential combination therapy with BCG and intravesical chemotherapy may be superior to BCG alone, but no large, high-quality randomized control has confirmed this. If this approach is correct, then outcomes will improve. The numbers of patients requiring radical cystectomy or radiation or systemic chemo will reduce, and also BCG supply will be better maintained for all patients with non-muscle invasive bladder cancer. So we aim to determine the effect of adding intravesical mitomycin to standard intravesical BCG after resection of high-risk non-muscle invasive bladder cancer. So this is a phase 3 randomized controlled trial. The study population is high-risk non-muscle invasive bladder cancer patients, so any high-grade TA or any T1 disease. Concurrent CIS is allowed, but CIS-only disease is excluded. The patients will be stratified by T-stage in the presence or absence of CIS. Arm A gives a standard BCG and maintenance schedule. We use the Fremantle protocol, which is 6 weeks of induction BCG, and then 10 months of maintenance intravesical BCG therapy, or the experimental arm, which is alternating BCG and mitomycin with a 9-week induction, and then a subsequent 9 further weeks of monthly BCG, mitomycin, BCG or mitomycin, as per the schedule shown. The study was run in 2 stages and funded in 2 stages. The stage 1 was really to show feasibility and completion rates, and that's completed. And then the stage 2 was to look at disease-free survival with secondary objectives of activity, time to recurrence, time to progression, safety, health-related quality of life, and overall survival. A number of exploratory translational biomarkers are being explored in further ongoing studies, utilizing the wealth of tissue that is available from this large clinical trial. That's the accrual curve so far. We've got 16 sites in Australia, 1 in the UK. As I say, stage 1 is completed and we're close to completion of stage 2. So what's the significance of this study? Well, a meta-analysis already suggests, meta-analyses already suggest that sequential combination immunochemotherapy may be superior to BCG alone, but this will be the first high-quality test of this. It's currently the largest recruiting non-muscle invasive bladder cancer trial, and we have actually got more than 480 patients currently recruited. It's providing a rich source of biomaterial for meaningful translational research, some of which may be presented at this meeting. There is a global BCG shortage, which will not be ending anytime soon. And of course, if combination chemoimmunotherapy is more effective, or even equally effective but less toxic, it will change the treatment paradigm for high-risk non-muscle invasive bladder cancer patients and significantly impact global practice. These are the acknowledgements. I'd particularly like to thank the patients who've taken part in the study. The study was entirely funded through competitive funding with Cancer Australia for the stage 1 and NHMRC for stage 2, though we have had industry support for the study as detailed on the slide. Thank you.